Welcome and thank you for attending tonight's Ahead of Cancer lecture series, sponsored by the Allegheny Health Network's Cancer Institute. My name is Michelle Stanicki, and I'm one of the program coordinators for the Institute. There are a few housekeeping items we want to go over before we start. Number one, during the presentation, all participants can type questions into the chat or Q&A portion of the Zoom. We will be addressing those questions at the end of the lecture if time permits. Number two, participants are not able to speak during the conference, but again, we encourage feedback via the chat option. Our topic tonight is the art of the cure, choosing the right treatments to cure prostate cancer. We are excited to have with us tonight Dr. James Betler, Dr. Timothy Dougherty, and Dr. Nasir Chaudry. And I'd like to take a minute to introduce you and give you a brief glimpse into their outstanding work. Dr. James Betler is a distinguished physician specializing in radiation oncology and is an associate professor at Drexel College of Medicine. He has been an active staff member at Allegheny General Hospital and other Allegheny Health Network affiliated institutions since 2009. His leadership roles include medical director for radiation oncology at Jefferson Hospital and system director of oncology care coordination in the southern region at Allegheny Health Network's Cancer Institute. He also directs the Cancer Institute's cancer screening and education programs. Dr. Betler earned his Bachelor's of Science in Nursing from the University of Pittsburgh in 1993. His pursuit of a medical career led him to the Pennsylvania State University for a post-baccalaureate pre-medical program, followed by his medical degree from the Lake Erie College of Osteopathic Medicine in 2002. He completed his residency in internal medicine at the Western Pennsylvania Hospital and obtained board certification in internal medicine. This was followed by a residency in radiation oncology at the Allegheny General Hospital, where he also served as chief resident. He is board certified by the American Board of Radiology in radiation oncology. His interests are focused on the innovative treatment methods in radiation oncology, with ongoing involvement as a principal investigator in several phase 3 clinical trials. In addition to his clinical and academic roles, Dr. Betler actively participates in professional organizations and committees, contributing to the advancement of oncology care and education. His dedication to both patient care and training of future oncologists underscores his significant impact in the field of radiation oncology. Next, we have Dr. Timothy Dougherty. Dr. Dougherty is a radiation oncologist right here at the Allegheny Health Network Cancer Institute, specializing in the treatment of GU cancers, which includes prostate, bladder, and kidney cancers. He also has a special interest in exercise oncology. He is skilled in advanced radiation techniques such as radiosurgery and stereotactic body radiotherapy, including MR-guided adaptive radiotherapy, as well as brachytherapy. Dr. Dougherty earned his medical degree from Georgetown University School of Medicine in Washington, D.C., and he completed his residency at the Fox Chase Cancer Center, Temple University Health System in Philadelphia, Pennsylvania. Next, we have Dr. Nasir Chaudry. Dr. Chaudry is a board-certified urologist in the Pittsburgh area. He's affiliated with the Allegheny Health Network and its associated hospitals, primarily Allegheny General and the AHN Wexford Hospital. He graduated from the University of Oklahoma College of Medicine and completed his urology residency at the Northeastern Ohio University's College of Medicine affiliated hospitals. Dr. Chaudry is board certified by the American Board of Urology. Dr. Chaudry has extensive experience in various areas of urology, including prostate cancer and kidney removal, and is a member of the AHN Triangle Urology Group located right here in Pittsburgh. Welcome, doctors. We are thrilled to have you here. I'm going to turn it over, I believe, to Dr. Betler, who will get us started for tonight's lecture.
Thank you, Michelle, for the warm introduction and the nice comments about all three of us. Tonight, we're going to be talking about prostate cancer. All three of us work very closely together with taking care of patients with prostate cancer. We have a multidisciplinary approach to this, both in tumor boards and also in a prostate center, which is unique to Allegheny Health Network in the tri-state area. So let me advance some slides here. Maybe. Oh, there it goes. So just an outline. I'm not going to spend much time on this, but this is what we're going to go over. We got about 47 slides, and we're
Dr.
going to.
Betler, can you share your screen, please?
Oh, sorry. Share screen. Is that the one or no?
Thank you.
No, that's not the
I
one.
think it is.
It is.
We see outline, Dr. Betler. I'm not sure that's the one you intended to share.
If you advance to the next one.
Do you see that now?
I see cancer screening and early detection statistics.
Okay, perfect.
All
Sorry
right.
about that. I can cure cancer, but I can't run a computer.
That's
Go figure. Okay, so let's go over some statistics first. These are hot off the press. So 2025 statistics. So in general, men and women are going to have a 1 in 3 chance of developing a cancer in their lifetime from birth to death. That's pretty high. For prostate cancer, though, men have a 1 in 8 chance of developing prostate in their lifetime. So prostate cancer, new cases, about 30% of all cancers, 313,000 plus men will develop cancer in the US. That's a prostate cancer. It's still the number 2 cause of death from cancer, right behind lung cancer. So this is a very interesting slide. This is the death rates that we see in men from 1930 to 2022. And I want to take a look here at a couple of things. One, the lung, if you look at that, this dip on it, how it starts going down is because of screening. We start using low-dose CT scans, and we're finding a lot more earlier stage cancer before it becomes a problem or before they present with symptoms, and that leads to better outcomes. So we could say the same thing about a lot of things. If you look at colorectal, we started doing colonoscopies, and we started doing FIT tests, Cologuard, other things. You can see the death rates going down. And with prostate cancer, we started using PSA in 1994, and we saw the same trend until we got around 2012. So there was a little dark area in our screening between 2012 to 2018 because U.S. Prevention Services Task Force, the government came out saying that they thought that we were doing too many screenings, finding too much cancer and over-treating. And so it took us 6 years to persuade them. But during that time, the dark years, they gave it a category D, meaning do not do it. And more recently, in 2018, they changed it to category C, meaning have basically a shared decision-making, a conversation. So there's lots of different organizations that have screening recommendations. We tend to follow the National Comprehensive Cancer Network because every year they come out with new updates on not only screening, but for treatment as well. But as you all know or don't know, that finding cancer early leads to better outcomes and less intervention by early detection. And that's why we saw those death rates with lung, colorectal, and prostate take a nice dip when we started doing screenings. So our American Cancer Society, they recommend an average risk guy start screening at age 50. If you have a high risk, if you're African American or have a brother or father diagnosed less than age 65, you start at age 45. And higher risk patients who have a first degree relative at an earlier age, then they start at age 40. Here's the dark years, category D, meaning don't do it because they thought we were doing too much overdiagnosis and overtreatment in 2012, revised in 2018 to category C, meaning at age 55 to 69, they say have a shared decision-making. And under age 55, there's no specific guidelines. And at age 70, they recommend against PSA testing. But I know a lot of people who have lived into their 90s and and if we stop screening at age 70, that could be a shortcoming for them getting, and they may have a shortened lifespan. So we tend to follow the National Comprehensive Cancer Network guideline. Their recommendations are, if you're average risk, age 45 to 75 to do screenings. And if your PSA is less than 1, you could do that every 2 to 4 years. If it falls between 1 and 3, you can do it every year to 2 years intervals. If it's above 3, we start getting more concerned that something's going on, and we should get you to a urologist like Dr. Chaudry for rectal exams and possible biopsies or closer surveillance. Those individuals who are at higher risk, and again, those are the African American men, those with a strong family history, or those that we know have a germline mutation like a BRCA mutation, they're at increased risk. So we start 5 years earlier. And we don't stop at age 75 with these guidelines. We do it in select patients. Obviously, if a patient comes in and they have pancreatic cancer and it's metastatic and they had normal PSA at 74, we don't need to do that anymore because they're less likely to live a long life having that metastatic pancreatic cancer, so we could stop. Or if a person has other ailments and they've had rock solid normal PSAs, we can consider not doing it anymore. But we still have in these guidelines the ability to continue doing it, not the hard fast, let's stop at age 70 like the U.S. Prevention Services Task Force says to do. So this is what we told the U.S. Prevention Services Task Force, and I dumbed it down and made it a little bit simpler. We should probably made it simpler for them, or they would have changed their course a lot sooner than 6 years. But when guys have low risk prostate cancer, and the second column here tells us who those people are. They have a Gleason score 6, have a low PSA less than 10, and we're not finding anything really on exams found on blood, or you're palpating some disease. Those men we tend to go and do active surveillance on. And if they have a life expectancy of less than 10 years and they fall into this category, we can actually even do observation and stop doing PSA levels. But again, I'm not God. Most people don't know when we're going to die, so we don't tend to play God or stop. We'll continue to do PSA levels for those men who want to continue doing that. But surgery's on the table, robotic assisted laparoscopic prostatectomy with pelvic lymph node dissection, and radiation's on the table, and we'll talk about some of the radiation options in more detail and further down the slides. So then we have intermediate risk prostate cancer, and these are the Gleason 7s. These are the guys who have a 3+4, we say they're favorable, and they only have one intermediate risk factor. Those guys who have an unfavorable of 4+3, and that means that the dominant picture is more aggressive and there's a smaller focus of 3, more average cancer. Those ones there we don't do observation on, or we don't do active surveillance. But the guys who have favorable intermediate, we can do active surveillance on those individuals too. When you get up into the unfavorable intermediate risk group, the cancers can be more aggressive and lead to a higher chance of spreading to seminal vesicles outside the capsule, to lymph nodes, or elsewhere in the body. So that's when we start to do treatment and we don't do any active surveillance anymore. And those are also individuals who can have 2 intermediate risk factors. And the intermediate risk factors for us are Gleason score 7, regardless if it's 3 or 4, 3+4 or 4+3. Those individuals who have biopsies of 50% or more, or those who have a PSA level between 10 and 20. All 3 of those are intermediate risk factors. You only need to have 2 of them to be catapulted up into unfavorable intermediate risk group. And then we get into the high risk group, and this is where we start using hormones long term for anywhere from 12 months to 36 months. Just step back for a second. The unfavorable intermediate risk group, we talk about using hormones short term, 6 months, and that is plus or minus because we use some genomic testing that helps us tease out those guys who are at a higher risk that need it and those who don't. I specifically use a test called Decipher, where if it's a score 0 to 0.45, looking for 22 different genes that make the cancer more aggressive, then you don't need hormones. When you get above 0.45, then you need hormones and you have more of those 22 genes. There's also an Artera that uses AI and looks at the slide from the pathology, and it looks for different markers that make the cancer more aggressive. But with high-risk cancer, that's when the cancer gets outside the capsule or into the seminal vesicles, or we have the PSA getting above 20, or we get into those Gleason scores 8, 9s, and 10s. And with those individuals, we start using the hormones, as I mentioned, for 12 months to 24 months, but we still have surgery on the table with these gentlemen as well. The very high-risk group is when the PSA gets a lot higher, above 40, or they have 2 intermediate risk factors, such as cancer outside the capsule, as I mentioned, invading another structure in the seminal vesicles, or they have the Gleason 8s or higher. In those men, we can use surgery, radiation, but we also, in this group, in addition to long-term hormones, we add a second-generation hormone, abiraterone, and they're both given for 24 months in this case. So these are just the AI tools, Decipher and Artera I just mentioned, and we use those to help us determine who needs to have hormones. And we also use them to tease out the gentleman who we might want to do active surveillance on. So if a guy has a low-risk prostate cancer, Gleason 6, PSAs between 4 and 10. But we find that he has a high genomic classification, then we may start to think a little bit closer about active surveillance, not doing it, or we may want to watch the PSA a lot closer rather than every 6 months and watch how the velocity changes over time, or the doubling time. If it becomes shorter, then step in a lot quicker. So I just want to put a plug in for our cancer screening program. Again, an ounce of prevention is worth a pound of cure, Benjamin Franklin. So if you go to this website, you can either get screenings, comprehensive screenings, every cancer screening that that you're eligible for on a Saturday event. We do these once a month at different locations throughout Pennsylvania. And then we have a weekday clinic that my nurse practitioners work out of, and they see patients on Mondays, Tuesdays, and Wednesdays at different locations, which I'll show you in a second. Right now, we have 3 events left for the year: Grove City in October, Hempfield, and Jefferson Hospital. The 2026 dates and locations should be coming out very shortly. The same website will have the availability for you to see where those dates and locations are. Or if you don't want to wait, you can always call this number 412-359-6665, and that can get you to one of our locations. We do the screenings at West Penn Hospital on select Mondays, every Tuesday at Jefferson, and every Wednesday at Forbes Hospital. So we're going to turn this over to Dr. Chaudry. Unfortunately, he's not able to do the video portion of this, but we're going to get him on the phone here, and we're going to advance his slides. So I'm going to stop sharing and let Michelle or somebody share his slides. Michelle, do you got it? Dr.
Hey,
Chaudry,
Marty, I got it. I'll grab it here.
Perfect.
Dr. Chaudry, can you hear us? Are you on the phone? Is he there?
So Dr. Chaudry did mention he had a level 1 emergency, which he might have had to step away for.
Okay.
Unless he's
No,
all right here.
I'm here. I do have a few minutes. I will have to step away in about 5-10 minutes, but I can do a quick little discussion if you guys can hear me okay.
I can hear you perfectly. Can everybody hear him online?
Are you seeing the screen?
I am not, unfortunately, seeing the screen. I'm actually currently
Jim and Michelle, am I sharing the slides? Am I sharing the prostate
Yes.
picture?
Yes.
Yes, I can see them fine.
Okay.
If you could, I can certainly discuss them. I don't need to see them.
Slide 1 is displayed.
Okay, perfect. So, I think the first thing, that you've already had a good overview on just prostate cancer and the basic statistics of it. When it comes to diagnosis of prostate cancer, you have to get a tissue sample in order to make a proper diagnosis. And there are basically 2 approaches to obtaining a tissue sample. One is to biopsy the prostate by
Dr. Betler, you went on mute.
Continue. Sorry, transrectal biopsy, you were saying. Good.
Okay, perfect. So a transrectal biopsy, the needle is passed through the rectal wall into the prostate. And with a transperineal approach, it's passed through the skin underneath the scrotum. Now, both of these approaches are very acceptable. And from a cancer detection rate, they're considered equivalent. There are pros and cons of each of the approaches. The transrectal approach does have a small risk of a bacterial infection. If you can imagine, the rectum obviously is a site of bacteria, and passing that needle through that rectal wall can introduce bacteria into the prostate, which then could potentially spread into your bloodstream. The incidence of this is very, very low, but it certainly does exist. The transperineal approach reduces this risk, but does tend to be slightly more painful. Passing that needle, through the skin multiple times underneath your scrotum can cause some discomfort. And because of this, we tend to do this approach under sedation. So if you want to stay awake, a transrectal approach is done more often. And if you want the transperineal approach, often that will require sedation, which sometimes patients do prefer regardless, because obviously it is a somewhat invasive procedure. A MRI fusion biopsy is where we start incorporating some of the advanced technology that has developed over the last 10 to 15 years. And with cancer detection, MRIs is another tool we can use to help localize cancer that could be missed on a standard biopsy. MRIs will usually catch what we would consider clinically relevant prostate cancer about 90% of the time. However, you cannot make a diagnosis just solely on an MRI. So you would have to obtain tissue sampling. And so the technology has developed where we can fuse the real-time ultrasound images that we obtain with the MRI images that allow us to target that lesion and biopsy it very kind of with pinpoint accuracy that just at times can allow us to make a more accurate diagnosis and hopefully hopefully avoid missing clinically relevant prostate cancer. All right, if you could advance to the next slide. So when you are past the diagnosis and you've had the diagnosis of clinically relevant prostate cancer, you're considering a surgical approach. Yeah, traditionally, there were 3 surgical approaches, but currently in this day, doing it robotically, which basically means that you would not make any big cuts, any incisions. Your belly would basically be insufflated and kind of blown up, kind of like.
Dr. Chaudry, we lost you there.
Do we still have connection?
We still have, yeah,
Borders.
we're on Wi-Fi. Dr. Chaudry, are you there?
I am there. Can you not hear me?
We can hear you now.
Okay, sorry. I don't know if I'm in a dead zone, but I was sitting in the same spot. So when did you lose me?
Inflating air into the
Yeah,
abdomen.
insufflating the abdomen.
Okay, so with a laparoscopic approach, we inflate the abdomen with CO2 that allows us to do a dissection without making a big cut and incision. And what this allows is it allows your recovery to be significantly better. Patients can sometimes go home the same day. Their pain level is very, very minimal. And overall, they get back to the more normal daily activity significantly sooner than the traditionally open approach. And this is why it has kind of almost replaced, and over as years go on, it will, continue to replace the more kind of old-fashioned approaches, just doing an open prostatectomy or something even called a perineal prostatectomy, where you would make an incision underneath the scrotum. And it's few and far between, and these numbers are just dwindling more and more around the country. All right, can you advance the slide? So the next slide is just a picture of what I'm trying to describe. And the Da Vinci robot, when you say robot, you never know exactly what that means, but we are in full control of the instrumentation the entire time. The robot is not doing the surgery. It just allows us to do very, very fine motor control. And on the picture, you can see what the whole setup looks like, and you can also see how your hands kind of control the instrumentation. And if you imagine, the pelvis is a very, very small area. And with the robot, you're able to basically do a significantly fine dissection around tissue that obviously is very sensitive, and there's a lot of structures that are running through it. So it allows you to do very meticulous dissection and allows you to do the procedure with minimal bleeding and connect everything that needs to be appropriate and really avoid any undue complications. All right, can you advance the next slide? All right, so the big question when it comes to surgery is, what are your realistic expectations? And I think this is kind of the meat of the discussion when it comes to surgery. And these are obviously sensitive areas of the body, and there's a lot of important structures that run through this space. And so when you look at what can occur following surgery, the big two things that are going to occur are potential disruption of your bladder control and potential disruption of sexual function. And these are the two big things that come into play. When you look at recovery of continence, there are a lot of factors that come into play. However, generally speaking, people will recover their continence fairly well over a period of time. But a realistic expectation is you're going to be having to wear pads and probably have to change multiple pads over approximately 3 months. At times, patients can heal faster, and at times, patients heal slower. There are rare instances, however, where you could have significant leakage that does not recover. This occurs very infrequently, probably 1% to 2%, but it is a scenario that could occur. The next scenario that could occur is potential disruption of sexual function. And this is what often scares men. The nerves that control your sexual function run on the backside of your prostate, and there are times that these nerves can be damaged or sometimes have to be sacrificed pending the status of your cancer. And this is a very individualized discussion that always happens on a case-by-case basis. But the general point is there can be disruption of your ability to have an erection. However, this does not always occur, and there are definitely times when you will have perfectly normal function following surgery. I do apologize. I am going to have to run. Unfortunately, I did have an emergency in the operating room that I am going to have to start at this point, but I will hand over the discussion back to the panel.
All right. Well, thank you, Dr. Chaudry.
Thank you very much. Is everyone still there? I'll do this one real quick. Are we sharing our screen again?
Yes, you
Yeah.
are.
Yes.
Okay, so that was a great oversight on surgery. And from the radiation standpoint, there's two ways basically to do radiation. One is externally with radiation, and the other is to put radioactive elements or catheters in and a radioactive source through those catheters into the prostate gland and treat from the inside out. So this is a nice overview slide from the National Comprehensive Cancer Network that we use their guidelines for screening. We also use them for treatment, as does insurance companies, because these are all evidence-based. And every year they're updated. This most recently was updated for 2026, and it just came out in August. So if you look at the top column here, top row, the low-risk patients, those are the ones that we tend to do observation on or active surveillance on. When you get into the favorable intermediate, those are the Gleason 7s with one intermediate risk factor. There's basically two approaches for external. It's either doing what we call stereotactic body radiation therapy, which is 5 treatments or less, or if we can't meet the constraints on the normal structures or the gland's too large or something else, then we switch to a hypofractionated, which in the past we used to do 40 treatments, and nowadays we do 20 to 28 treatments. At the bottom here, these external beam radiation therapy, EBRT with boost technique, that's when we see that there's a nodule on the MRI, and we'll fuse the MRI with the CT scan that we use for planning, and we'll give that area a little bit more dose per day as a boost simultaneously. So if you look across external beam, these two approaches, the SBRT, are check for favorable, unfavorable, high risk, very high risk. When we get into the high risk and above, we start moving more towards a combination of external to cover the whole pelvis, followed by a boost with brachytherapy, because there was a trial showing a 19% improvement at 10 years and a 27% improvement at 15 years over doing just external beam radiation. So that's kind of how we practice in our group, unless there's some reason we can't do a brachytherapy, such as the gland's too large, prior TERP, where they remove part of the prostate gland to make a man be able to pee better, and other things that are more specific. But when we get into regional lymph node involvement, that's when we start using external beam alone. This next slide is showing you the combinations or monotherapy. Monotherapy, it's either with seeds or with catheters placed into the prostate and a radioactive source, basically a radioactive source on a wire goes through each of those channels, each of those catheters, and treats from the inside out. And we'll talk about both of those a little bit more in a few slides from now. But the combination, as you can see, when we get to high risk, that's when we use the combination. And in select cases with the unfavorable, intermediate, or very high, we'll use the combo of treating the whole pelvis with external radiation and then a brachytherapy boost. And now Dr. Dougherty is going to talk to you about something that is unique to Western Pennsylvania, an MRI LINAC to treat with external radiation. No one else has it around here. And
Sorry.
Dr.
Great. Thank you, Dr. Betler. So to start this conversation, to get to the MRI linear accelerator, it's important to kind of go over the history of external radiation itself. So this is an image of a traditional linear accelerator. The top gantry here you can see is what is administering the radiation. You can see the person getting treated on the table and then the therapist lining them up. So here's a brief history of radiation over time. This is a very cheesy and corny tagline, but I like it. Millimeters matter. So we'll see as we advance and we get more and more precise, we can see that we deliver better treatment with fewer side effects. So this is kind of the 90s to early 2000s. There's a lot of acronyms in radiation. I don't want us to get hung up on it too much, but this is 3D conformal radiation therapy. This image is of a person lying on their back, sliced like a loaf of bread. What's important here is that this red circle is the prostate. So I don't expect people to really understand all the anatomy, but the two things to point out are this red circle is the prostate, and this brown circle is the rectum. So we want to target the prostate and we want to minimize dose to the rectum. Now you can see in this technique, these lines are the dose. So the highest dose is the red dose. And you can see kind of this whole box is getting that amount of dose and then less in these other kind of lower, these other colors. So then we advanced and we came up with IMRT, which again, another acronym, but essentially you can see, again, we have this low dose area in these lighter colors, and then you have the prostate again in red circled here and the rectum in brown, but you can see there's now much lower dose going to the rectum. And so as technology advanced, we were able to better administer our radiation treatments in a more conformal way. And this is really just showing that, in fact, the side effects were better. So the blue line is that first treatment, the 3D treatment, and the green line is the IMRT treatment. So you can see a pretty significant decrease in rectal side effects, which again, just looking at the images, you can see this rectum is covered in the red area, and this has much less red. The same is true for urinary function. So these are the side effects that we worry about. And again, as we advance technology to the green line, you get better urinary side effects. So where are we now? So there are a few things that we've been able to improve over time since this era. So first thing I'll talk about is fewer treatments. Historically, we gave treatments over 40 different times for 8 or 9 weeks. And we've realized that we can give the same amount in a shorter period of time, and we can do that safely as technology has advanced. I'll also talk about adaptive planning, which is really the luxury that we have here at AGH, especially with the machine that we use, the MRI guided linear accelerator, which again, not every place has, and this is a really kind of exciting thing to be able to give to people. And then last thing, smaller margins, which again, pointing out to the MRI machine, we can do this because we have real-time monitoring with magnetic resonance imaging. All right, so fewer treatments. So again, historically, radiation gave treatments, small doses every day, because we realized we wanted to be safe and we wanted to be sparing of the rectum and the bladder. This took a long period of time, but over time, as this kind of graphic shows, we gave the full treatment. Now, moving forward, we've become more precise. We can give higher doses per treatment. And so we can give essentially what the body feels as the same dose, but instead of giving it 40 times, we give it 5 times. It's much more convenient. It's equally as effective, if not potentially theoretically better. There's some caveats there, but this is kind of the general paradigm shift. The next really exciting thing is adaptive planning. So anatomy can change day to day. When we bring someone in for radiation, we bring them in for a planning scan. It takes us about 2 weeks to plan the radiation. So you can imagine 2 weeks later, your anatomy might look a little different. So again, here's that same image. Again, don't expect you to be an expert on the anatomy, but this blob right here is the prostate, and then this circular organ is the rectum. So you can see how close they are. Again, this is someone lying on their back, sliced like a loaf of bread. Now, we contour the prostate, and then we contour or color the rectum. But as you can see, these two images are slightly different. So I picked somewhat of an exaggerated example, but this is, I think, helpful to illustrate the point. So this is what the new anatomy would look like if I overlaid that old image. So you can see the interface between the prostate and the rectum is here. So we're missing the prostate. And here's this, again, overlay, this back and forth that you can see. What we can do now is we can do what's called adaptive planning. So what the person came in with, it's different today. And now we can say, let's change the plan. Let's make the rectum look like the rectum today. Let's make the prostate look like the prostate today. And we can adapt the plan and create a new plan specific for this person on this day, which is a really great feature that we're able to do. And then the last thing that I want to mention is smaller margins. So again, millimeters matter. So sticking with this, again, this image, the person on their back, lying flat, sliced like a loaf of bread, prostate, again, rectum in this image. With any radiation treatment, there is some level of uncertainty just based on setup day to day. We can't be 100% precise, but we've gotten quite good. This is an example of actually where we were not too long ago in terms of our uncertainty level. We realized that with better imaging techniques, we can shrink that down. So this might not look like a lot, or it actually might look like a lot. This is only 2 millimeter difference to kind of put it in perspective. So if you look at a ruler, at home and look at 2 millimeters, that is this difference, which again, might seem when you say it quite small, but when you look at it visually, you can see this pink line is overlapping the rectum, whereas this green line is now avoiding it. This is now a slightly different photo. This is someone standing straight up and it's kind of sliced in half. Again, I'll just, not important that you know the anatomy, but this is the bladder. The area circled in red is the prostate, and behind it is the rectum. Again, you can see this pink line is really touching the rectum down here and starting to go up into the bladder. When we shrink the margins, even by 2 millimeters, which again doesn't sound like a lot, we can really stay off these structures better. And this has really been shown to be true. So we take a low risk of side effects and we make it even lower by shrinking those margins. That's what this blue to red graph is showing. And same thing here as far as bladder side effects. So it is effective when we shrink these margins. So even these small differences do make a difference as far as side effects for bladder, urinary, and bowel side effects. The last thing I will say, one way that we do this to make the margins smaller is we use real-time imaging using MRI guidance. And so right now I will show a video. The most important and probably easiest example is the image on your right, so the right screen. Again, person standing up straight, sliced in half. The area in green is the prostate. The bladder is lighting up. This looks a little bit different because this is an MRI, not a CT scan. We were looking at CT scans before, and then the rectum is behind it. So this is what we do really on a daily basis. So this is actually playing, and we're watching the prostate in real time. Now I've chosen a good example where the prostate isn't moving much, but if the rectum fills with gas, and I'll play it one more time, the rectum fills with gas and moves the prostate out, or if the bladder changes shape and the prostate changes, we can stop treatment, we can adjust. And so it has really allowed us to shrink our margins down and be very confident with our treatments. So in sum, over time, we've been able to give fewer treatments as we get more precise, higher doses per treatment, more convenient. We've also had the ability to adapt treatments, making, again, treatment much more precise from a day-to-day basis and minimize any variability. And then we've also been able to use smaller margins. And so where does this lead us? The main side effects that we worry about as radiation oncologists tend to be more related to rectal and urinary side effects, frequency, urgency in both of those domains. With all of these advancements, there are fewer side effects, and importantly, with the same or better effectiveness. I say better because we're able to target things and adapt treatment and make sure that we're not missing the target. So really a lot of exciting stuff and changes in the field of external radiation treatments. So I'll turn it over to Dr. Betler, who will talk about the internal treatments for radiation.
Thanks. So I just want to add another couple of things about the MR-Linac, which is really nice. When I spoke before about the micro boost, when you're able to go and use an MRI to outline where the tumor is, the nodule inside the prostate, when we're treating, we can see that nodule and make sure that that extra dose, that simultaneous boost, is hitting the correct area. And Dr. Dougherty is 100% right. Whenever, we'll see people have gas that moves on and the rectum starts to move forward, we'll pause it. We'll ask them to move to pass their gas, or layman's term, fart. And then once they move their air, then the prostate can move back in position. We can resume treatment. And you don't get that on every machine that you get treated on. But in our world, what we found with radiation is that more dose, more kill, more success is the simplicity of what we do. So I've heard people ask me, what about proton therapy? Well, proton therapy has been looked at side by side with the IMRT, which is intensity modulated radiation therapy, and the study showed no difference in outcome and no real difference in side effects. So a lot of people who have a proton unit, they paid lots of money for it. It's great for kids and reducing the amount of radiation to organs that are around where they're treating, but it has not shown any improvement in treating prostate cancer. But when they have something, they need to make the payments on it. So a lot of times they advertise and market it, which is why in Pittsburgh you have not really seen a proton unit pop up. Because we in Pittsburgh don't treat enough children with cancer, and a lot of children here will go to St. Jude's or elsewhere, and there just has not really been an improvement with proton units. The MRI unit, the MR-Linac, a game changer with being able to see what we're treating as you're treating it. But again, we still have to go through normal tissue, which limits how much dose we can give safely, because you have the rectum, behind the prostate, you have the bladder on top. With brachytherapy, oftentimes we'll use it as monotherapy. It's either one or two treatments, depending on if you're doing a low dose rate or high dose rate. And when you're putting a radioactive source into the prostate and treating from the inside out, the dose falls off very rapidly. Brachy is Greek for short therapy. So you can get to a higher dose, and a higher dose means improvement in outcome. More dose, more kill, more success. So I just want to contrast the two. We do them both in our system, and in Latrobe also. I go out to Latrobe. We do the high dose rate out there with that group out there. But for monotherapy, low dose rate is where we're putting seeds. Everybody hears about seeds, radioactive seeds. It's been around since the 1950s, where HDR has been around since the 1980s. So 30 years more experience, more studies on it, and it's a one-time procedure. And with high dose rate, we do 2 procedures, usually within 2 weeks of one another. At one of the schools, American Brachytherapy Society prostate school that it goes on every other year. I go to that just for updates. One of the hospitals actually presented with high dose rate versus low dose rate. They went back and looked. They used to do 4 treatments of high dose rate, and then they did 3, and now they're doing 2. But they looked at their control and the PSA level, which is basically how we follow them in afterwards on how successful the treatment was. And they saw that the seeds, the one-time dose, had a similar pattern for keeping the PSA down and success as doing 4 treatments. Nobody today does 4 treatments of high dose rate. We do 2. And there was a little bit, not even that it might be significant statistically, but there was a little bit of a less PSA control by doing 2 fractions as opposed to the 4. So as a boost procedure, though, after we do external, like in those high risk groups where we treat the whole pelvis for 23 treatments, we could do LDR or the high dose rate. It's 1 procedure there. Time on the table, time for the procedure, usually an hour or less for me to do a seed implant, where high dose rate's probably about 2.5 hours, sometimes push a little bit longer, up to 3 hours. As I mentioned, 1950s is when LDR began, 1980s is when the high dose rate began. And let me tell you about the difference between the two. So the approach is the same. You go to sleep, best sleep of your life. When you wake up, you have a sore throat because we put a tube down to protect the lungs from any secretion so you don't get pneumonia. And then we come over and we put a Foley catheter in. We remove the scrotum and the penis out of the way. We tape them up, and we do some betadine, and we also give you an antibiotic IV while we do this. And what we're doing is we're putting a rectal ultrasound probe into the rectum, and we're looking at the prostate in 2 dimensions. And one is, if you think about a prostate like an orange, you pluck it from the tree, lay it on its side, cut down the middle, and hold it up. You see the peel, the fruit, and you see the center. That is cut in the body coming down like this. The other view is the long view coming side to side, where we see the bladder on top, the prostate length, and the rectum sitting behind it. So what we're doing is we're looking on our ultrasound monitor for the biggest orange slice, or the biggest slice of the prostate coming down like this. And on our monitor, there's a template. We're getting that orange slice, prostate slice in the middle of that template. And down between the scrotum and the anus, the perineal area, we have the same template there. So once we get the prostate in the proper position, we lock down the ultrasound so we don't have to hold it anymore. And then we play battleship. We look at the monitor and figure out where we need to put our needles through the template between the legs, through the skin, through the fat, into the prostate, and showing up on our ultrasound monitor. We put it in at mid-gland, the biggest slice, and then we switch the other view and advance them to the top of the prostate. Once they're in place, that's where the difference begins. At that point, we either go and take images and capture them in a laptop computer, either on ultrasound, 3D view, or individually every 5 millimeters coming down for the low dose rate, 3D with the ultrasound for the high dose rate. And with the low dose rate, with the seeds, we're figuring out how much radiation is being delivered by those peripheral needles where I'm going to put seeds in, and the number of seeds I put in is whatever the length of the prostate is plus 1. I tell the computer that, it fills in the dose, knowing how much the strength of each of those seeds are, and then the center is always cold. And that's where I have to sit down and figure out where do we put the central needles and how many seeds do we need to put in there. But typically we're putting somewhere between 60 to 100 seeds in. Once I get the central needles placed in and they're all advanced to the top, then I start putting in the seeds. And I put it in with a device called a MIC applicator. It's like a gun. It has a kind of like a rod in the back that I push. It goes through the center. And at the tip of it, there's a little area that a cartridge goes in that has the seeds in. It has a hole on 2 sides of the cartridge where the stylet goes through the first hole, pushes the seed out through the second hole, through the needle that's attached to, and I see on the long view the seed drop into place. And then when I pull the wand back, the next seed drops down, and I move the needle to the next position, putting these symmetrically in a row. And then they stay there, they're there for life. You're radioactive with these, so for the first 60 days, we have a little bit of precautions with kids and women who are pregnant. The government has no restrictions, but we're more conservative. So we tell you to remember time, distance, and shielding. You could hug a grandchild, you could hug a pregnant woman. We just don't want them sitting on your lap for long periods. Distance, 3 feet is what our discharge instructions say. I tell everybody, remember social distance, 6 feet. The dose drops by 1 over the radius squared. And then shielding. So we don't want you to buy the lead covered underwear off Amazon. The guys sharping people and making money for no reason. But your hip bones absorb more of the radiation than the front or the back. So if you're driving in a car, you put the kid behind you. If you're the driver, if you're the passenger, they go behind the passenger. If you're sitting on a couch, have the kid to the right of you, not sitting in front of you on the floor. With the high dose rate, after we put the catheters in, we go and remove the center metal piece, and then we lock down the catheters in place, and we connect the radiation machine to the catheters through cables. And each of those channels, after we've done the 3-dimensional rotation of the ultrasound, and I sit down, I draw in the prostate on every slice, outline where the urethra is and the rectum. And then we tell the computer how much dose we want to give to the prostate, but not to the urethra, bladder, or rectum. And it figures out the Rubik's Cube on how long does that radioactive source on a wire need to go into each of those channels up to the top of the prostate and sit in different positions, dwell positions as it's coming back. Now, it's close to a structure like the urethra, it's going to move a little bit quicker. When it's further away, it'll spend more time contributing to that whole plan. But once we figure out the plan's checked by myself, 2 physicists, and then we deliver the radiation. And once the radiation is done, we come in, remove the machine, remove the cables, remove the ultrasound probe, and take out the catheters that are in the prostate, hold some pressure, stop it. And then we have to do the same thing within 2 weeks later. If we're doing monotherapy, if it was a boost procedure, it's one and done after the external. The side effects, there tends to be in the literature less erectile dysfunction with LDR, more erectile dysfunction with HDR. Guys who have a lot of calcifications in their prostate, we may lean more towards high dose rate because it's more penetrating through that calcifications or bones. There tends to be a little bit less urinary symptoms with the high dose rate than with the low dose rate. So if a guy has a high urinary score, severe, we may lean more towards the high dose rate. All guys who get brachytherapy, we put on Flomax. That makes the bladder squeeze more forcefully to better empty and push the urine out of the bladder through a swollen prostate that occurs about a month after each of those procedures. The duration of the urinary symptoms for low dose rate, I tell my patients expect 4 to 6 months, where the high dose rate's about 2 to 4. Very rarely is it a year, but I always give my patients a year of Flomax. Some guys find, doc, I pee like I'm 16. I could write my name in the snow, dot the I's. They want to stay on the Flomax. There's no harm. It lowers your blood pressure a little bit. So I tell them to take it opposite of their blood pressure medicine if they're taking it so that their blood pressure doesn't drop too much. It could also cause a retrograde ejaculation or a dry ejaculation. I'm not so worried about the rectum because we're able to spare that very well, whether it's LDR or HDR. At the same time, if I'm concerned if somebody has inflammatory bowel disease on blood thinners, or I think that they're going to benefit from a procedure called a rectal spacer, I'll put those in at the time of brachytherapy, where we put a gel that dissolves over 6 months in between the prostate and the rectum to push the rectum away, so there's less chance of getting any radiation. And then afterwards, as I mentioned, both you're radioactive with the LDR, HDR, you're not radioactive, so there's a little bit of limitations as we discussed with the LDR versus HDR. There's not. Just some pictures to show you. That gun, here's the gun right here. The gentleman's holding it. Between his pointer finger and middle finger is nothing there. In the second picture, there's the cartridge, the clip for the gun. It goes in the center here, and then this attaches. There's a hole on each side of this cartridge where the rod back here, when I push it through, pushes the seed out deploys it into the patient through via the needle, and then moving the needle back, we can put it in different positions. In the OR, this is what it looks like. On an X-ray afterwards, this is what the seeds look like in the prostate. On ultrasound, this is what they look like, and you can see the dose falls off very rapidly, 200% of the prescription down to 150, down to 100. So brachytherapy, short therapy, as I mentioned. On CT scan, this is what it looks like. These are the seeds. This is how big the seeds look like. They're like a piece of rice, the diameter of a piece of lead for pencil in comparison to a pen. And on HDR, the approach is the same. It's just either putting the seeds in or using the radiation on a wire to deliver the radiation and temporarily and then removing it. This is what the afterloader is, where the radioactive source on a wire is. These are the cables connecting to the catheters that are in the prostate. This is the grid where it's locked on. And this is what the needles look like before we take them out of the catheters. And this is what a plan looks like. These are the catheters that are in on a CT scan, and this is the dose that is being delivered. You can see the rectum is far away from the prescription dose. And one important thing about our program, as I kind of alluded to in the beginning, is that we have a prostate cancer center where the urologist, the radiation oncologist, and sometimes the medical oncologist will all come together on certain days of the month, and we see patients that are referred into our prostate center. It's you come in, you get all three of us or all two of us, definitely all two of us seeing you at the same time, and we sit down and collaboratively discuss the patient in between after each of us see and think what is best for that patient. If that was me, how would we best treat that patient? And it's not radiation's the best, or if I'm a surgeon, surgery is the best. It's what is going to be the best fit for that patient, and then we come back and let that individual know, and that's quite unique. This started under some of my predecessors many years ago, Dr. Miller and Dr. Fuhrer and Dr. Cohen, and we've kept it going. And it's really a unique cancer center approach to patients. And it started because we'd have patients who came and said, my doctor, who's a urologist from some outside facility, says, do surgery. And we'd have another person we'd see for a second opinion from a radiation oncologist, and they would say, my radiation oncologist said do radiation. And we look at the patient and say, clearly, the guy telling you radiation, you're better suited to do surgery or vice versa. So we're always telling the patients what's best for them. But ultimately, it's the patient's decision. We're just there to help guide you and take you down the right path to make sure that we're curing you with the least amount of side effects possible. And this is the link to the prostate center. Thank you, and any questions?
Dr. Betler, I would encourage you to read and reply to question number 1. It's pretty extensive, and it probably would be best for a typed answer for that response. But the next question I'll read to you is,
I'm gonna let Tim look at that as I read this. Go ahead.
Okay, the next one I'll say, this question is, I've been told about HIFU ultrasound treatment. Are you familiar with this? Does this have less side effects, and is it effective?
Actually, I can answer that one once you read this one.
Yeah.
So with HIFU, the NCCN, National Comprehensive Cancer Network, collaboration of urologists, medical oncologists, radiation oncologists, all coming together. They meet every year and update. Their guidelines say that HIFU is recommended in the setting of a failure for radiation or along with cryotherapy, which is freezing the prostate. That said, guys, as we talked about, who are on active surveillance, there are some individuals we will do HIFU on if they are wanting to extend their ability to stay on active surveillance, and we can see a dominant nodule on the MRI, because you have to see what you're treating is the best way with HIFU. But we also look at the complete picture. If you have a very high Gleason score, 8, 9, 10, you're less of a candidate. If there's calcifications, that makes HIFU more of a challenge to treat the prostate. So I don't know your individual stories, but if you're a gentleman who can go on active surveillance longer and kick the can down the road for doing radiation or surgery, and that's the choice you choose, it's not inappropriate. Many high functioning centers, us included, use HIFU in that setting. And it does not take off the table the ability to go back and do a definitive treatment for the whole prostate, whether it's removing it surgically, doing radiation, doing a seed implant, doing high dose rate. That's still always on the table. What it's doing is it's allowing gentlemen to be on active surveillance longer, and it does not treat the whole gland. So you continue to need surveillance closely with PSA levels. The treatments for treating the whole gland, because again, the biopsies, sometimes they're random. It's like throwing darts. Sometimes you hit the bullseye, sometimes you don't. If you move the biopsy needles different millimeters away, You might find different grades of cancer with the treatment approaches of surgery or radiation, external or an implant. You're treating the whole gland, good cells, bad cells, not letting the good cells eventually become cancer cells potentially down the road. With HIFU, you're not treating the whole gland. Did that answer, hopefully?
I think so. That was very comprehensive, Dr. Betler. And then if you guys can just type the answer back to the other person, and then I think I'll hand it over to Michelle to wrap it up in the interest of being respectful of everyone's time. We're at 7:01.
I can
Michelle?
answer that question very quickly,
Oh, okay. Okay.
So just very briefly, the question is about PSA screening after a negative biopsy now that the person is 77 and in good health. So this was back to what Dr. Betler was saying. At 75, the recommendations become a little bit more opaque. It becomes a conversation with your doctor. In good health, I think it still makes sense to get PSA screening. I would put a plug for trying to get a prostate MRI as well, because that can help evaluate if there's any suspicious lesions in addition to the PSA. And then ultimately, it would be up to your team if another biopsy was warranted. I do think, we definitely don't want to overtreat people, but someone who's in good health, following up, I don't think there's anything wrong with continued screening, but I would put a plug in for an MRI before you would get a biopsy or something like that.
Yeah, and I'll just add to this, you really need to look at the individual who's sitting in front of you. If you have longevity, have great ancestry, everybody lives to 90s to 100, and you're in good health, don't have diabetes, don't have hypertension, haven't had cardiac events, all of those things, and you've had a concern that a PSA is rising, then yeah, it makes more sense to keep following that. Doing the MRI also allows us to know how big your prostate is, or measuring with an ultrasound probe, because the PSA, when it goes up, does not mean you have cancer. It means it could be elevated because of enlarged prostate, urinary retention, an infection in the prostate. Lots of things make it go up. But the reason why at our screenings, I'm looking at the note from the gentleman. The reason why we do not go and screen people at our screening events after 75 is because we have to follow the U.S. Prevention Services Task Force at those screening events, because it's what CMS, which is the people who follow the rules for reimbursement, do. But on a one-to-one individual with your primary care doctor, he has known you longer, and at a screening event, we don't know you that long. But at your primary care doctor or your urologist should be able to sit with you, because they have a longer rapport of knowing you and knowing if you're one of those people in select, as the NCCN guidelines say, should continue to have screenings. And lots of men continue to have screenings well past 70, 75 years old, because they're in good health, and a lot of people are living longer, and we don't want to shortchange somebody because of a number.
Yeah, good question.
Yeah.
All right, thank you.
Great question though. Let me just look one more time, see if there's anything else. Nope.
Okay, Michelle, you want to do the wrap up?
Sure. I just want to thank everybody. I want to thank Doctors Betler, Dr. Dougherty, and Dr. Chaudry for the excellent lecture tonight. Excellent topic, excellent everything. So thank you for giving your time tonight. And I would also like to thank you, the participants who joined us this evening. Thank you for attending our Ahead of Cancer lecture series. As a reminder, this lecture will be, it was recorded and will be uploaded to our YouTube channel. For all the participants on this evening, I will be sending out a link to that. And if you or anyone you know is interested in seeing a physician in our Cancer Institute, please feel free to call our Hope line at 412-578-HOPE. Once again, thank you and have a great evening.
Thanks,
Thank you.
everyone.
Bye-bye.